Good morning, everyone, and thank you for having me here. Today I'll be presenting a new approach to management of SFA, CTOs, a novel hybrid score and algorithm. I have no disclosures. This is a 63-year-old gentleman with, who presented to us with bilateral lower extremity pain. He had class 4 Rutherford rest pain. His past medical history was significant coronary disease, hypertension, hyperlipidemia, chronic tobacco use, and known PAD with multiple remote interventions. He was taken to the vascular lab and ABIs were done, which showed significant reduction in his in flow, bilaterally worse on the left than the right, involving both above and below the knee segments. And so we took him to the cath lab, and we started with right common femoral axis as a 7 French sheath taken up and over, and a contract catheter in the left common femoral artery. As you can appreciate, there's an occlusion in his right SFA, almost at the ostium, and multiple non-overlapping stents in the SFA, and as well as in the popliteal artery in the left leg. The popliteal artery was also completely occluded, and he had a single vessel runoff down to his foot on the left. And so we proceeded with antegrade crossing attempt, and starting with wire escalation, tried to wire into the occlusion. However, we had limited success, and the wire kept going into a sub-intimal space. So we quickly escalated to an OCT-guided CTO crossing device using Ocelot, and we managed to get into the advance our equipment down in our base of operation into the mid SFA with wires. However, further advancement of wires was unsuccessful. And so at this point, we went through the pedal access with a retrograde crossing approach. Under direct visualization using Schmett's technique, we stuck the PT with a micropuncture and was able to put a 6 French sheath and get our Ocelot device from below again with a wire. But despite our best effort, we were not able to direct the CTO crossing device into the distal popliteal stent. What I don't show here is that we also attempted a re-entry device, the outback device, to try to redirect our equipment to the stent. However, that was also met with unsuccess. And so next we proceeded with direct access into the proximal popliteal stent under fluoroscopy and ultrasound guidance. We got a micropuncture there and advanced our wires. We were able to take the wire up through the femoral SFA stents and managed to pop back into the common femoral artery. Got a followed that with a microcatheter, and then and wired into the sheath and externalized using a 5 French sheath through the 7 French and created a rail there. Thinking that, well, we did most of the work there, we switched our approach back to the antegrade, got a quick cross catheter down. However, despite several attempts to wire into that distal popliteal stent, due to the non-overlap area here, we were not able to get the wire to go through all the stented segment down to below the knee. And so here we rallied our surgeons and we discussed our options. The guy had previously multiple times refused surgical approach here, and he had a sub-optimal target being very low there below his below the knee, and so what we ended up doing is we advanced our retrograde wire all the way in the vessel architecture back to the common femoral and the sub-intimal space, obviously, and then we used that wire to wire back into the sheath and create another rail. And at that point, we decided to do our stent crush. So what we started with is pre-dilated the sub-intimal space using a 1-to-1 sized balloon. starting with a 5.0 and then a 6.0 in the more proximal segment, and then we deployed 5 overlapping nitinol high compression resistant stents. In this case, it was a Supera stent. We stacked it pretty high to maintain the highest amount of resistance, radial strength and compression resistance possible. And this was our final result here after we deployed our stents and post-dilated them. You can appreciate that the patient had excellent flow through the stented segment with restoration of 3-vessel runoff into his leg. The total amount of dye that we used was about 180 cc's, and we used about 1.1 grays. Patient was maintained on DAPT and sent home the same day without complications. 6 months later, we brought him back to intervene on his right leg, which was done. And in the same setting, we took pictures of his index leg, and that shows that our stented area remained patent with some elongation in the stents, which we kind of expected with the high stackability that we did. But we maintained 3-vessel runoff into his leg. And so this is data from our own institution. We analyzed about 160 SFA CTOs and put together the factor score, which is in a way similar to the JCTO score in the coronary realm. And we use the factor score to develop the factor algorithm, or to help operators facilitate progress through SFA occlusions, standardize the approach, and validate the factor score. And based on our own internal data, we were able to show that the higher the factor score, obviously the lower chances of technical success, but also the higher the chances that you'll need multiple access sites to achieve success. So in conclusion, SFA CTOs are a challenging subset of lower PAD. Alternative access site proficiency is paramount in increasing procedural success. The newly developed factor score can be used to predict complexity, success rate, and number of access sites needed for successful SFA CTO, revascularization, and limb salvage using compression-resistant nitinol stents deployed in the subintimal space to crush adjacent stented segments, creating a new lumen, is a feasible approach in patients with critical limb ischemia and limited alternative treatment options. Thank you.
Thank you. Just in the one or couple of minutes we have, I wanted to ask you, do you guys have laser? Because, you know, when you got from above down to the 3/4 SFA, you couldn't go any further. Laser is a good option that I've used, where you can actually, even without a wire across, just go put the lasers, you know, all the way down to where you cannot go anymore. You do short bursts of laser, you advance the wire a little bit, short burst of laser can help you go through definitely a stented area where it's very resistant. Or that option was not?
It was. We often use laser, and in this case, I think we had tried even the stiff end of a wire to go through with very limited success. I think we could have considered that option. Absolutely.
Any other comments?
So, if I heard it right, you said you guys placed 5 stents. Were they like on top of each other just to gain radial strength, or they were like just short stents and just overlapped all the way through?
They were overlapped to maintain as high compression resistance as possible, basically.
So I've done one where I've only used one Supera behind the knee to crush the previous stent, and it usually works well. These stents are pretty solid radial strength. You don't. I mean, you overlap them if you need longer segments, but I don't know if necessarily you need to put 2 stents inside of each other.
No, the overlap was not too big. I'm just saying, but it was a very long segment that needed the 5 stents,
make
and the high stackability is correct.
I see.
Correct.
So, in this patient who has rest pain, chronic problem, and has already failed extensive SFA popliteal stenting, what do you think is the durability of this sort of para-vessel stenting? Because basically that's what you've done. You've created a new lumen next to the true lumen, which I think is, you know, I think the endovascular skills, and I call them acrobatics, but I think that's pretty amazing. But, you know, at the end of it, it's not like you're trying to heal a wound. Like, if the goal is to heal a wound, then maybe you just need it to be open for like 6 months so the wound healed, and then they return to their regular level of ischemia. But rest pain is going to be a chronic problem. So,
Right.
what?
So he had very poor lifestyle at the time. He wasn't able to do much, we talked with the surgeons about what can we do for this guy, and that was the last resort type of thing for him to get any sort of symptom relief, because yes, we're talking about wrist pain, but nobody wants to live with that either. If we can give him some relief of their symptoms, even for potentially limited time. Now we brought him back, as I showed, and we re-imaged at 6 months, and the stent stayed open, which was promising, and we continue to follow him up, and he, actually after both intervention, he's feeling great now. So for what it's worth, it worked for him, maybe not for everybody. That's true.
All right. Well, thank you, Luai.